Hi, everybody. Welcome to OrthoHub. For those of you who are joining us for the first time, welcome. And for those of you who have been to some of our events before, welcome back. Tonight, we're hosting another great event. And in the past few weeks, we've worked really hard to put together another fantastic lineup for you, which tonight is going to focus on the shoulder. So without further ado, let's just get down to a little bit of housekeeping before I introduce you to tonight's host, Livio Damascio. The speakers tonight are going to be Hanan, Graham, Lennon, and Livio, and I'll let Livio introduce those guys in a little bit more detail further down the line. For those of you who are already familiar, we also follow up our webinars with fantastic podcasts. The most recent podcast we did was actually with Professor Tim Briggs, who was talking about the future of orthopedics and girth, which is obviously a big influence in all of our lives and careers at the moment. But after each event, we invite one of our key speakers to talk to us in a little bit more depth about themselves, about their practice, but also about some of the finer points of the content of the webinar, which of course on this occasion will be shoulder instability. So we're really looking forward to Graham Tytherleigh-Strong joining us for a podcast, which we're going to record fairly soon, and that will be released in the next few weeks. And of course, you can go back through our catalogue of podcasts, and the most recent one prior to that was an excellent podcast with Lee Van Rensburg talking about elbow problems. We've also got some more exciting content coming up after this, and the next event that we have planned for you is going to be on tibial plateau fractures. So we're putting together an excellent lineup and a masterclass in how we approach difficult problems in tibial plateau fractures. And that's going to be coming up hopefully in the next couple of weeks, and you'll hear more about it on our website and on our social media links. And that's going to be on Wednesday, the 25th of November. So without further ado, I'm going to hand you over to our host for tonight. A big thank you to Livio Damascio from Barts, who many of you will already know. And he is going to be our host for the evening. So Livio, over to you.
Hi there. Thank you so much, Ramon. Well, what an evening we have in store. So we are going to be talking tonight to three excellent invited speakers. And I'm really sort of standing on the shoulder of giants today. These guys have got a wealth of experience in shoulder instability, as you know. Shoulder instability is a big problem, particularly in contact and collision athletes. And there is perhaps a lot of discussion how this should be treated. And Hanan Mullet is going to start today with speaking to us about the first-time dislocation. Hanan joins us from Dublin, where he's one of the surgeons who helped develop the sports surgery clinic, where he's based and works with like-minded sports physicians and surgeons. He's got an absolute wealth of experience in arthroscopic surgical reconstruction, where he's focused his career and treating the elite athletes. Hanan was the founder and current president of the Irish Shoulder and Elbow Society and maintains a practice in complex trauma. He also does that at Beaumont Hospital. So he's going to talk to us this evening about first-time dislocation. Now, throughout all of these talks this evening, I'd be very keen for all the attendees, there's lots of you out there, if you have any questions, to actually put them on the chat screen. And I'll try and field them, and we will have some discussion after each talk. And then we'll have some summary of thoughts at the end. Okay, so put those questions in. Don't be shy. This hopefully will be, a very good Q&A session as well, not just didactic lectures from these fantastic speakers. So take it away, Hanan.
Thanks, Livio, and thanks to the OrthoHub team, particularly Ramon and Mike, for inviting me to this fantastic webinar. It's always a great pleasure to have the opportunity to talk shoulders with Len and Graham. So I'm going to talk a little bit about first-time dislocations. The decision-making here centers about the degree of structural damage, gleaning information from the history, exam, and imaging, the patient's needs and expectations, and their expectations or their acceptance of risks and benefits either with conservative or with operative intervention, and it's all about shared decision making. I'm going to talk a fair bit about what the evidence is in 2020 for surgical intervention for the first-time dislocator. So these patients, the first-time dislocation group, they generally fall into one of three groups. The first is those that definitely will need surgery, and I'll talk a little bit more about these. The second are those where we're definitely going to go down the conservative route initially anyway, and depending on their age, comorbidities, and their enthusiasm for sport. But the nub of the issue really is the group in the middle, the patients who possibly may benefit from surgery. So the definite indications for a first-time dislocation include a shoulder that's irreducible. So for example, in this case, where there's soft tissue interposition, namely the subscapularis, there's a blocking reduction, or when we reduce the shoulder and it pops out fairly smartly again, and this can be due to either soft tissue interposition or commonly a significant bony lesion, and this is an indication for surgery. Or if they have a rotator cuff injury, typically in the older patient, we see a tear of the posterior superior cuff, or less commonly in, for example, this patient here, recent rugby player who managed to avulse his subscapularis when he dislocated his shoulder. We also may need to address associated fractures such as a greater tuberosity fracture or a significant glenoid rim fracture. And also, I think we all agree that in high-level sports, depending on the sport and season, this is an indication for the first-time dislocation. So in terms of the possible surgical candidate, we need to think about the pathology and the player. We look at the mechanism of injury, whether it's high energy or low injury. The reduction history can be informative. For example, if it's easily popped back on the pitch by the physiotherapist, it's less likely to have a significant structural lesion than if the patient has to go to the emergency room and have a difficult reduction procedure. We get some information from the history of the other side. So if they've required reconstructive surgery on the opposite side, we generally have a fairly low threshold for surgery on the newly affected side. I'll touch a little bit on the examination and the radiology. Well, Len is going to tell us a little bit more about the major and minor lesions which can guide treatment. And then the player, Len's going to talk a little bit more about the factor of the player in the surgical decision making. Level, the time of the season, where they are in their career, and often things such as impending fixtures. So when we examine the patient, we look for predictors of increased risk. So we look at laxity, we look at the neurological examination, because we know that approximately 10% of patients, sports patients that dislocate their shoulder, are going to have some element of neuropraxia. And sometimes, for example, if they have axillary nerve neuropraxia, this is going to make their shoulder unsafe for early return to play. And this may in fact give us a window of opportunity to repair the soft tissue component. We look at their range, because some of these patients would develop stiffness. Probably the most useful clinical sign in determining the effect of bony lesions is the mid-range instability sign described by Bushnell in 2008. So if you examine the patient in some 45 degrees of abduction, external rotation, and if you provoke apprehension or pain, this is a fairly specific sign for a bony lesion. Some of these patients also get a complete shutdown of the cuff, which can influence their ability to return safely to play. And we often see, particularly in the rugby players, where they have a massive deltoid, this allows a lot of compensation for the associated injuries. So in 2020, this is the definite evidence we have that surgical reconstruction of the first-time dislocator is important. So one is that they have an unacceptable high risk of recurrence. The second is that surgical intervention can reduce the recurrence rate. The third is that there's improvement in the quality of life conferred by surgery. And the fourth is that recurrent instability causes significant and progressive soft tissue and bony damage. So Havelius has the longest term follow-up of first-time dislocators over 25 years, and they've shown an unacceptably high rate of recurrent dislocation, particularly in those under the age of 25. And Robson et al. In this paper, which is referenced by the best BOA patient care pathway in traumatic anterior shoulder instability, again shows that particularly under the age of 30, particularly young males, have a very high rate of recurrent instability. So what about the effect of surgery? So there's a number of good quality papers showed that surgical intervention reduces the recurrence. So Botani in a GSM 2002 showed a 75% recurrence in non-surgical versus 11 in early surgical. Cassandra Kirkley in 2005, well, she showed two things. One, that there was a much higher recurrence rate than non-surgical, but also that there was much better quality of life in those that you stabilized early. And Jackson et al. Also showed a much lower recurrence rate in the non-surgical group. Mike Robinson, in a very nice study, has shown over a 10-year follow-up looking at arthroscopic washout versus arthroscopic stabilization, that there's a 4-fold increase in recurrence in the washout group. And in fact, we have just published a paper in arthroscopy with our colleagues in NYU, which was a systematic review and meta-analysis of the literature looking at studies comparing arthroscopic bankard repair with conservative management. So we used standard Prisma methodology to analyze the papers, and we found 10 papers which were all of high quality level 1 and 2, all had high methodology quality of evidence scores. And to summarize it, there was 270 non-operative versus 299 arthroscopic bankard repair. And as one would expect, they were mainly young males with an average follow-up of 66 months. So the results were that the recurrent instability rate was 7 times higher in the non-operative group. The subsequent surgery for surgical instability, again, was 7 times higher in the non-operative group. And there was a significantly significant difference in return to play favoring the arthroscopic stabilization group. And Matt Provincia, in an editorial in the journal Arthroscopy, his conclusion was that given the low patient rate following arthroscopic stabilization, early surgical intervention should be considered following the first instability event. So the players and the parents often ask the surgeon, well, what about if he dislocates it again, doc? Is he going to cause more damage? Well, the evidence would suggest that this is definitely so. So what about abscess lesions? Well, these two papers from Matt Provincia's group and from Yiannakopoulos' group show that they're looking at the difference between primary pathology in primary versus recurrent, that there's a much higher rate of abscess lesions in the recurrent group. The Yiannakopoulos paper also indicates that there's a much higher level of Hegel lesions or capsular rents in the recurrent group. What about cartilage damage? Well, Provincia and Millett looked at primary versus recurrent and showed more cartilage damage in the recurrent group. It's obviously very important, the size of the Hill-Saxon recurrent lesions. And Nakagawa, they looked at critically measured the Hill-Sachs and glenoid defects in both the primary and recurrent group, and were able to demonstrate that as the more times you dislocate your shoulder, the bigger the Hill-Sachs lesion. And obviously, glenoid bone loss is key. So Griffith et al. In this paper, 2008, they showed that glenoid bone loss significantly increases in a cascade fashion with the greater number of instability episodes. And again, these two papers, the Nakagawa paper and also this, both from AGSM, Dickens paper, looking at the evaluation of bone loss after primary and recurrent anterior glenohumeral instability, show that the number of instability episodes is directly correlated with the degree of glenoid bone damage. So that's the evidence, the definite evidence. My own personal opinion is that if you stabilize the soft tissues early, you have a better chance of getting back to sport earlier and the soft tissues are likely to heal more reliably. So this is, the reasons for this is that I think that if you repair the soft tissues early, that you're performing this in an excellent healing environment. So this was a recent patient. So in fact, there was a degree of pressure to get this player back, and he dislocated in training, and we managed to stabilize him on the same day. You can see the, although it's a little bit bloody, the view in the upper right, looking at the small Hill-Sachs lesion, you can see that the soft tissues, the labral tissue, just looks like if you put it back anatomically, it's just going to want to heal. And the ACL literature in terms of early fixation is strongly supports this. There's also, if you look at the basic science literature, there's evidence that in the first 7 to 9 days post-injury, you're going to have your maximum circulating macrophages, T lymphocytes, hematopoietic cells, and other nice factors that are going to help your soft tissues to repair. So as the great Bard said, if it were done when it's done, then it were done quickly. This applies to the first time dislocation. Finally, what about the patients that you're not going to stabilize? Well, the key thing here is to assess the risk for the patient of further damage. And the criteria to return are minimal pain, minimal apprehension, good range of motion and strength, and critically, for the other stakeholders, can they do their job? So I'd like to thank you for your attention, and I'm looking forward to the rest of the webinar.
Excellent. Thank you so much for that talk, Anand. Brilliant. So at the moment, nobody's actually posted any questions, but I've got some questions myself. So a lot of the patients that we see, they're not necessarily going to be playing for the Ireland First 15, and may not necessarily be collision athletes. If you were to see somebody who had modest sporting ambition, as it were, and let's say they were 27 years old, and this was the first time traumatic instability episode that they'd had, an anterior dislocation following, I don't know, falling, playing football. What would your recommendation be with regards to imaging and treatment at that point?
Well, that's I suppose the key issues here, I'm not sure about the NHS, but in our health service, if a patient if we see them in a public clinic, the pathway then, or the ability to get sophisticated three-dimensional imaging, either MR or CT, is limited. So I mean, if we see a patient where we have access to imaging, I think it's very helpful in terms of the decision making to get an MRI scan. So if it's available, I think you can certainly you can give the patient a much more informed opinion as to what the prognosis is. I mean, you'll have a lot of information from their their age and their sport. You'll get the plain image. You may see an obvious bony lesion on the plain image, and then it depends on the interval as to when you're seeing them. If you're seeing them, let's say 3 weeks after the episode, if they've already got a comfortable shoulder, they're getting good range of motion, they don't have marked apprehension signs, that might give you enough information. But I mean, generally, if the circumstances allow, and if we have access to typically an MRI or a CT, that'll help us guide the information or the decision making.
Thanks. And you'll go to, if you had a choice. So our French colleagues quite like a CT arthrogram, but is is your choice MRI arthrogram or a CT arthrogram, or you're not too fussed?
Well, I mean, in the setting of the patients who are playing at a reasonably high level and have access to imaging, I mean, the most common group of players we see play Gaelic football, yeah. And there's about 400,000 people play it in our country of a population of 5 million. Well, there's an insurance scheme for them, so we can always get a scan for those people. And if you get an MRI, a non-contrast MRI scan, within about 7 to 10 days, generally the blood in the joint will act as a contrast. So you get a very good study. You don't necessarily need to put contrast in. So a normal MRI scan generally will give us sufficient information. I mean, if we're very concerned about a bony lesion, or there's something more abnormal, or if we're, you know, in a revision setting, then we're looking more for CT. But I'd say my go-to, you know, for first-time dislocator is plain films and an MRI, plus minus MRI with contrast if the presentation is a bit delayed.
Okay, thanks. There's a question from Joan Freitas. What about does non-overhead athletes that suffer a first-time dislocation, is their treatment different to any other type of sport?
So non-overhead or overhead?
Well, yeah, the difference between overhead and non-overhead, I guess.
Yeah, I mean, I must say my experience of overhead athletes is I mean, maybe we could bring Len or Graham in on this, but I mean, I would say probably in terms of the sporting population, I'd see they're 90% collision athletes, where we don't tend to see too many cricketers or high-level tennis players or diving soccer players. It generally tends to be collision.
Okay.
I would think the chance of managing them non-operatively is probably much higher, or, you know, delaying definitive treatment and managing them in season. And I'm sure Len will enlighten us further on this, but to get them through critical times in the season is much easier in the non-collision player.
So Paul Cowling has posted a question: is three-dimensional imaging always necessary for first-time dislocation? If you've proven there's no bony injury on X-rays, I guess the question is, would you consider doing a diagnostic arthroscopy and repair as, you know, repair a soft tissue structure without imaging?
I mean, in our setting, the patients who would be coming for surgery, i.e. those that are playing sport at a relatively enthusiastic, if recreational level, they generally, I wouldn't be operating without some kind of three-dimensional imaging in the current environment we practice in. Yeah.
Okay.
So I mean, generally, if you have, you know, the chap who falls off his bike and doesn't have any major bone lesion on his X-ray, and his cuff seems to be working, and he's you know, he's at low demand, they're going to go down a particular pathway that would probably see they have a recurrent instability episode. So I mean, my talk really relates to the more enthusiastic or, you know, high-level recreational player.
Sure.
Yeah, I think just with Hannah, I think there's a bit of a difference, certainly in the UK, NHS side and private side. So most of the sort of professional athletes come and see you privately, and you can get scans pretty quickly. On the NHS side, I saw there was a question about sort of timing. So if you are going to fix someone up arthroscopically, really you've got probably 2 or 3 weeks max to actually really do that surgery. After that time, because of the sort of beginning of the healing, the fibrous tissue, the tissues become sort of quite poor quality, and that's actually not a great time to do it. And really on the NHS side, and I also see patients, just because there's an element of delay, if we really want to try and do something, sometimes getting an MRI scan is going to delay them. We just can't get that done. So in that situation with these guys, I sort of, as long as there's no obvious sort of bone loss, I'll sort of jump in and scope them and be prepared to do it. Obviously, there's a caveat if I say to them, if I find something completely different, but I think so sometimes it's a needs must. The private is completely different because you can get all the imaging that you like, but just in the NHS sort of setting, it's just really difficult to get an MRI scan and then actually get that surgery done in. I've got a trauma list that I can do that on, but realistically, I'm looking at a 2, maximum 3 week window. Once it's gone past that, I think the boat is sort of a set sail for the acute repair.
Yeah, I certainly agree with your comment that you either strike very early, or after 2 weeks, the tissue tends to be very friable. I mean, it's a bit like the ACL scenario. I think you're better off either do it in the first, you know, week, 10 days, that kind of window, or leave it till 6 weeks? I'd be interested on Len's vast experience on that, particularly with the high-level players, when there's a certain pressure to get them back. If they're, how would he feel about operating, let's say, at the 3-week mark to do a arthroscopic soft tissue reconstruction?
Somebody's asked, what about the Artisan trial? I think that's the Warwick study that is looking at sort of single shot advice versus rehab. I mean, I think everybody will agree that, you know, a part of what we do is the surgery, but you know, rehabilitation is hugely important as well, particularly with, you know, shoulder stability. How does that, you know, how important is the physio and the rehab as part for your pro athletes? And, you know, is that something that we can actually transpose into care of our weekend warriors that we're treating? Is that, will we get better results if we treat them better with physio?
Is that Artisan is if you go non-op though, isn't it? I think.
Yeah, I think it is. I'm not. Have they published the results yet?
I think they're still doing it, but I think it's just your non-op ones, whether you just fire them off.
Just say, here's a sling and get on with it. You know,
Yeah.
here's a book and a fishing rod, and then there's a program of physio for the other guys. I mean, would you think that would be helpful? I mean, physiotherapy is likely to improve, you know, your dynamic stability, proprioception, scapular control.
I think it probably would have more of an influence in the higher level athletes, because they often have, their shoulder is better primed before the injury. They have a very strong deltoid. They've maxed out on the rotator cuff strength. They're very au fait with rehabbing all types of body parts, and they, you know, they're very adherent to any program that's given to them, because their livelihood depends on it, and their position in the team depends on it. So, I mean, I think, I know Len's going to talk about the in-season management of them, but I mean, yeah, I mean, the chances of them, and the kind of the American football literature would support that if you have a professional player, a lot of them, they can make it through the season, so you can do something out of season. But, you know, I'm not sure the guy you see in the fracture clinic who's fall on the way home from the pub is probably not going to get the same stellar results.
You see a few of those, do you, in Dublin?
Not at
the moment.
For 6 months.
Okay,
there's been no pub opened in Dublin for 6 months, so.
Right. So I think I'll try and field. I think there are a few more questions, but we'll move on. So we're going to now move on to Len. So Len Funk is going to talk to us about what's the title of his talk? So anterior glenohumeral joint instability in the contact athlete. So Len, many of you will know, he's been practicing as a consultant orthopedic surgeon at Wrightington for, you know, 18 years or so. And he's evolved his practice to pretty much exclusively focus on sports and soft tissue injuries around the shoulder. He works at Wrightington Upper Limb Unit and has practice at the Arm Clinic in Manchester. A lot of you will know Len from shoulder.co.uk, which he's used as a platform, sort of like this free platform orthohub, to actually educate his patients. It's a free resource, and it's actually hugely helpful to physicians as well. So I think many of you may already be familiar with that. Much of his practice is arthroscopic shoulder and reconstruction, second opinions and revisions of screw-ups that perhaps could have done better elsewhere. And he has a tremendous amount of experience that he's going to share with us tonight about elite athletes, the treatment of them, and probably the management of all the other people that come along, including the manager and the head of medicine and physiotherapy, etc. So they're a difficult bunch to deal with, and I'm sure he's better than most at dealing with them. So take it away, Len.
Right. Thank you very much, Livio. And huge thanks to OrthoHub for giving us this opportunity to get on stage with the guys again. Always nice to catch up with Hannon and Graham. It's a fantastic platform, the way you've set up the orthohub, and I'll get my subscription in. So my talk, I'm going to follow on from Hannon, and as Hannon pointed out, we're focusing on the amateur athletes with experience from professional athletes as well. And I'll sort of take some of Hannon's points and highlight them and expand on in the terms of the decision making. We know the recurrence rates are very high non-operatively, and particularly with the younger athletes. And we've been looking at this, and my practice over the last 12 years has been younger and younger contact athletes. So we looked at this and we found that a lot of studies refer to patients under 20 or under 21. But actually, when we stratified them, we found a big difference between those under 16 and over 16 in terms of the adolescents, in terms of recurrence rates. And these are for contact athletes and not for atraumatics. And with younger players, one of the reasons is we found a lot more bony Bankart lesions, and the anterior inferior growth plate closes by the age of 25 years of age. And this is maybe one of the factors contributing to the higher recurrence rate with patients younger than 25, and particularly the adolescents. When we looked at the lesions within these contact athletes, you can see, looking at the anterior lesions, as Hannon pointed out, a high incidence of bony Bankart lesions at 20% and a high incidence of ELPSA lesions, which again, Hannon pointed out, higher recurrence rate with those lesions. So we know from studies that arthroscopic stabilization does give better results. So when we looked at in these young athletes return to sport and other studies, it's not as high as we'd like to think. And there's a number of factors within that. When we looked at the longer term recurrence rates, it was quite higher than we would have liked as well, with a lot of patients being revised and a lot being revised to Latarjets. So Olivia earlier mentioned about the Latarjet, and the Latarjet has become increasingly popular, particularly with contact athletes, and I'm sure you all know what it is. We looked at our Latarjet outcomes, and there's lots of studies with very similar results, but I like to look, audit our own results and present those. And we found that unlike the arthroscopic stabilizations, the recurrence rates were very similar in the adolescents as they were in the adults, with a good return to play. But even though you get those great results, they are associated with risks of complications, and there is a role for non-operative management. And the Lawton study, an old one, showed that half of younger and adolescent athletes can do well with physiotherapy and felt much better. There's a great study on Mike Freehill and his team, which showed that a large proportion of in-season athletes with instability episodes are able to return to their sport and complete the season. And interestingly, only a third of those went on to have further instability episodes and surgical interventions. So I think it highlights that we shouldn't just focus on the pathology, on the bony injury or the labral injury, but we have to think about the patient factors and the pressures. So in terms of the lesions, I like to divide them into the major lesions and the minor lesions. The major lesions are those which we know are associated with higher recurrences, such as the bony Bankarts, the ELPSA lesions, the associated cuff tears, and Haggle tears, whereas the minor lesions are labral tears which are undisplaced and partial cuff tears. AC joints different. So, you know, Hannon highlighted the examination and determining the patient factors. Sorry, Hannon, I stole these. And, you know, we know age is important. The younger patients, males, higher risk of recurrences, hyperlaxity, higher risk of recurrences, also fatigue. So towards the end of a season, and if patients, particularly amateur athletes, aren't suitably fit, the type of sport, and we talked about that in the discussion, also the player's position. So forward in rugby union has different functional demands to back. And then again, Hannon highlighted some of the pressures. So the timing of the season, what have they got coming up? What are their targets? You know, if they've got a really important end of season final game in 4 weeks' time, if they have surgery, they're not going to be playing that game. So that's got to be balanced as part of your shared decision-making process. Also the pressures on them by their teammates, and also particularly in the younger age groups, where you have guys that are going to be potentially signing up for clubs. So if they have surgery, that may limit their chances in season of being able to show and be able to be signed up, and their targets. So therefore, in terms of timing of surgery, an early surgery would definitely be those patients with a large structural lesion later in the season, and the fact that they're unable to return. So within a few weeks, they can't get back, well, you may as well operate because they're going to lose a lot more time anyway. And those that you can rehab and return will be those that are able to get back and play. They're responding well to early rehab, and they have minor lesions, and it's earlier in the season. So where's the role for the Latarjet? It's not for everyone. Certainly this is within my practice, this is where it definitely is. So for revision surgery, even if they don't have bony loss in a contact athlete, any anterior revision surgery, chronic bony Bankart, there's studies showing good results with acute bony Bankart repairs. Porcellini's study, Sagaya, we published it, and any degree of bony glenoid loss. So, you know, it's not a percentage, any bony glenoid loss. For a front row forward nowadays, any true dislocation, I tend to go for a Latarjet, and higher level of sports as shown in the ISIS score. So again, remember, think about all these factors equally, the pathology, the patient factors, and then also the pressures required on them. Thank you very much.
Thanks, thanks, Len. Start my video, done. Another brilliant talk. So Len, you know, just like Hannon, you see a huge number of collision athletes. And it's sort of interesting that you, you know, on that last slide, or was penultimate slide, you go, you know, rugby union, any front row forward, they've got an episode of proven anterior instability. You have to do a Latarjet from the outset. And presumably that's because you've been...
No, sorry, true dislocation.
Yeah. A true dislocation, but in a front row rugby union forward, because they're binding with their arm up here, and you know, inevitably the scrum collapses and what have you, so they get hyperabduction, external rotation.
Absolutely.
I assume you've sort of come to that conclusion because you have been burnt. You've done soft tissue reconstruction, and they've had further dislocations, or is this just something that you think makes sense, that you know their shoulder is so vulnerable that they need belt and braces to stabilize it?
No, it's from, as you say, it's from experience really, and also because the scrummaging has changed in the last 5 years. So the position that, as you say, they have to get into with the binding arm is quite extreme now. And I tend to find I get earlier and better range of movement with a Latarjet than an arthroscopic stabilization, and more predictable. So yeah, that particular group, in my experience, tend to get back quicker with a Latarjet.
And you do your Latarjet as an open procedure, as sort of, yeah.
I do now, and don't see myself changing again. Sorry, yeah. Graham.
Len, not at all. I've realised that there's actually no difference in the outcome in truth, and that's because it's the same procedure. Yeah. There's no arthroscopic advantage because you still have to go through the subscapularis. So occasionally there's some good reasons to do arthroscopic, but I mainly do open now.
Yeah, scope is just an approach.
Yeah, it's just an approach. I mean, I think there's, the new sort of suture button eden-hybinette has got an advantage because it actually, you can go through the rotator interval, so you don't actually go through subscapularis. So it's actually a different operation from the open one. And an arthroscopic Bankart's different from an open because you don't go through subscapularis. But an arthro Latarjet, when you walk away from the patient, you've done exactly the same procedure. So not surprisingly, the results, they don't get better any more quickly. It's the same operation. When
you do your eden-hybinette and you do it arthroscopically, you are really just addressing what one would think is a bone defect rather than the associated soft tissue defect that they have.
Yeah, no, so I was going to maybe just highlight that in my next talk, is really that I think that sometimes people talk about bone block procedures and they think an eden-hybinette and a coracoid transfer are sort of interchangeable. I think eden-hybinette just extends the glenoid arc, but I think the reason Hannah and Len and I like the coracoid transfer is the dynamic sling. So so they are different procedures. I mean, they both have got their relative merits, but they are different procedures. And I think, some people think, well, my bone block procedure is one or the other, but I think actually if you're doing a lot of these, particularly revision, you have to really be able to be sort of au fait with both of them.
Yeah.
I'd be very interested in what Len is doing for, let's say, the 15-year-old aspirational high-level rugby player who has recurrent instability, given the high rate of failure with an arthroscopic stabilization.
Yeah.
So I think, Hannon, it goes back to the shared decision-making process. If you have a guy who is definitely going to be signed, this is going to be his career, and he's going to be a professional. This is a key stage of his career. If he's going to be out after 2 operations, and I've seen this, that's the end of his career. He wants one operation that's going to get him to be a professional rugby player with a low recurrence risk. So, that's the answer. Somebody asked if long-term outcomes, generally long-term outcomes, they're going to get arthritis whether you do a Latarjet or whether you don't do a Latarjet or whether you do a stabilization. We don't have any data to say otherwise. If the only concern, and you have to explain to them, if he has a failed Latarjet, that's a lot worse than a failed arthroscopic stabilization. So, it's how important that rugby is. If he's going to be an accountant and he might play rugby at university, that's a completely different situation.
Yeah.
Patient factors.
Len, I think that's a great point with regards to, obviously, 15-year-olds, the parents involved, 16, 17. I mean, you've got to give as much information to the family, the patients. We've done particularly on the NHS side, I think the professional athletes, it's not that you have to persuade them they want surgery. We did a little study, so obviously in Cambridge, everyone is always asking probing questions, and what I found with guys who sort of NHS who are sort of recreational, quite high level aspiring sports sort of people, we give them a leaflet, chat to them, and I'd say that 1 in 3 patients who I think are people that were probably, there's an indication to fix them up. They actually they go away and they come back the next day or phone up and say they want to do it, and then about 2/3 of the ones that don't want to do it are fixed up a year later because they didn't take that advice. But I think you can take a horse to water, but you can't make it drink, so to speak. So I think, just as Len said, I think you've just got to chat to these people and explain all the things. But we can only offer this advice, and then it's up to people. But as long as you feel you've given them all the information, I think they ultimately make the decision.
Somebody's asked the question, how quickly would you get somebody back to sport if you do a Latarjet? So this is, I mean, my experience is that I'd be slightly more aggressive with regards to return to sport with a Latarjet with bone healing than with a soft tissue reconstruction. Is that what you guys think, or are you that you go equally slow with both?
Well, I don't think it should be a time-based decision.
Sure.
I think we do know the average time, but that might be different in different practices and different surgeries. It can't be a time-based decision. There has to be the healing factors, there has to be the rehab factors, and the demand or pressure factors, and they're all really important. So it's when the patient's ready and they've achieved the end stage milestones which you've set for them. And a lot of the time that depends on the quality of physiotherapy. We do the same operation each time, but the physiotherapy will significantly, even using the same protocols. So it's hard to say, the average time is about 4 months in my practice, but that can range anywhere between 3 and 12.
Yeah. But do you see a trend if you, say, for example, do, your open Latarjet versus an arthroscopic reconstruction?
Well, I don't do them on the same patients.
Yeah,
so
sure.
No, I don't see a difference. But when I did do more stabilizations for similar patients, the Latarjets got back quicker.
And Hannon, you mentioned that sort of like in your athletes that you would consider doing an early repair because you've got good healing and good biological factors and good soft tissue. Do you feel that if you repair them sooner, that they're more likely to get back to their activity level as gauged by their rehab quicker? Do you think?
Absolutely.
Yeah.
I think the ones who have a lesion that's suitable for an arthroscopic repair, usually first-time dislocators, no significant bone damage, position specific as well in rugby union. I think if they have a very good soft tissue that you repair early, I mean, some of those can get back, like 10 to 12 weeks for rugby union. So they're
but again, your decision-making process would be dictated where they are in their season and what their aspirations are.
Yeah, but I'd agree 100% with Len that it's not time-based. It's due to their recovery and how well they're performing. We're actually doing quite a big study at the moment. We have a PhD student looking at the biomechanics in terms of isokinetic testing and also using force plates to put the patient into various loading positions, like dropping on the ground and falling from a height in different patterns, to try to see if we can predict what elements of that predict return to play. So it'd be interesting to see what that shows up.
I found more recently, I perhaps sometimes say to these guys, everyone always asks how quickly can you get back, and to take a little bit of pressure, well, it's not pressure off, but I sort of I'm quite into the Cybex testing, and I'll say you've got to be within 95% of the other side. And I think actually the patient then realizes that it's not necessarily going to be strictly on time. And I think it gives them a better idea that there's going to be a little bit more sort of variation. But I think I'm sure Hannah and Len, the biggest stress from these guys is they always are asking about, and the team, when are they going to get back? And you just don't, I mean, they're a bit like political, all these political commentators. They're always trying to ask the same question to an MP to try and get them to give them the answer in a sneaky way. So they're constantly asking about this time, but you've got to be sort of firm and just really sort of bat it back to them and just say, you know, it's not about time. It's about when you meet certain parameters. You can give them a rough indication, but
I usually just go by, before I've done the operation, I look to see what the news website has said.
Yeah,
I'll be back and
exactly. Yeah,
back from there.
Yeah, exactly.
Cool. Okay. Thanks, guys. So let's go on to Graham now. Graham, Tytherleigh-Strong, again, brings a wealth of knowledge and expertise. You've been at Addenbrooke's for about 15 years or so, focusing primarily on arthroscopic surgery and arthroplasty in the shoulder. It's pioneered a number of techniques, including sternoclavicular joint arthroscopy, which I guess the first time you do, you need a spare pair of trousers. Something I didn't know before. I think a couple of years ago, I went out with Graham, and he told me that he was he did a limited commission in the British Army before he went to university. So he's quite handy with weapons and things, I guess. He remains active academically now, and he does a lot of training for the higher surgical trainees fellowship program out of Addenbrooke's, and he's very active at teaching nationally and internationally. So he's going to talk to us about the failed instability, which sort of goes on very nicely from what we've already been talking about. So take it away, Len.
Lydia, thanks very much for that introduction, and thanks Rowan and Mike for organising everything. And it's great to sort of be with Len and Hannon. It's great these guys always give wealth of knowledge, and it's quite nice to be reassured we've got sort of similar practice, just to make sure we're still on the same page. So I'm going to talk about failed instability. I noticed Hannon's first slide was fix them and forget them. Well, that's what I used to think. That's not always the case. And recurrent dislocations, you know, all operations, things go wrong. And the longer you practice, the more operations you've done. So you're going to get more dislocations. And actually in Hannon's study, he said, you know, Bankart tears, probably about a 10% recurrence rate. There are lots of papers here and there, but 10% is roughly where we are. Contact sports, we know it does go up. And for the Latarjet, less than 5%. And the prognostic factors, or the negative prognostic factors, are younger age at the time of their surgery, younger age at their first dislocation, also multiple dislocations. Most of these studies that are quoted are actually really looking at the redislocating at 2 years. So most figures that are quoted at 2 years. So that 10% is really at 2 years. Unfortunately, there's a late recurrence. So really for the next 3 to 5 years, almost the same number occur again. So actually probably the recurrence rate as time goes by actually does increase. But it seems once you've got past 5 years, 6 years onwards, it seems to decrease. And I don't know whether that's to do with their activity. So it tends to plateau off at 6 years. The other thing is, when we're talking about failure of instability, obviously the biggest thing is dislocations. That's a really obvious thing. But when you actually talk to patients about, you know, how satisfied they are, there are other factors. So subjective instabilities, they may not be dislocating, but they're having issues with subluxation instability. And then there are other problems, particularly sort of stiffness. And so there are many other factors. So if we're just looking at dislocations, there's a failure rate there, but probably for dissatisfied patients, it's a little bit more. And that's why we use scoring systems. You can see on the right, this is a very stable shoulder. It's never going to move again. So that's not going to re-dislocate, But I'm sure if you put a scoring system, so scoring systems are quite important as well, just to see how people have done. But for this talk, we're going to sort of concentrate on dislocators. So reasons for failure, there are probably three reasons. There was the initial patient selection, so perhaps it wasn't the right patient to do the surgery on, or you chose the wrong surgery. A technical error at the time of surgery, or basically you can have the same injury again, and particularly the type of people, the younger people that we're doing this surgery on, they've injured their shoulder playing rugby or skiing or what have you, and they want to go back to that. So there's just the same chance that they could injure themselves. With patient selection, really, we know about the Stanmore triangle, so really the polar type 2 or type 3. So if they've got hyperlaxity or muscle sequencing, then they're the patients that you really want to avoid. And we still do see some patients that perhaps have had some surgery, but that surgery was never really going to help them. It's really to do with physiotherapy. And then it's probably an inappropriate procedure. So obviously, we've talked about sort of bone loss. So if you don't appreciate the bone loss, particularly bipolar bone loss, so it's not just what's happening on the glenoid side, it's the humeral head and engaging Hill-Sachs lesions. That can be a problem if you don't appreciate that and you just go soft tissue. And on the soft tissue side, sometimes it's not necessarily it's an inappropriate procedure, but perhaps it's not an appreciation that actually sometimes these tears, particularly they sometimes go around the back. So some of these patients, they may not be dislocating, but they've still got some posterior instability. So it may be not appreciating all of the soft tissue errors. And then this is perhaps alluding to what Len was talking with the ISIS score. So they looked at why patients who had a soft tissue stabilization sort of failed. And I think that some of these younger patients, they've got a tissue inadequacy. So you can do a soft tissue procedure. As Len says, a lot of these younger patients, they can redislocate and they haven't really got that much bone loss. So it's perhaps their soft tissues aren't so great. So thinking about that, so that really that sort of scoring system. And then technical error. So soft tissues, I think we're all getting very good at doing soft tissue Bankart repairs, but I do think sometimes we just think it's a relatively straightforward operation. You just put the 3 anchors in, you pull the tissues together. And sometimes we don't necessarily do as great a job as we can with our capsular shifts. So sometimes you can fix it too medially. These are a bunch of slides that have actually got metal anchors so we can see what's going on. But you can actually see these on the MRI scan. So sometimes if you put your anchors too medial, that's not going to help. Sometimes you get insufficient shift. So actually you don't really go high enough. So you don't actually really shift up sufficiently. And sometimes you can actually have an incorrect shift. So sometimes there's something called a flask deformity. So actually you don't really go low enough. So actually you pull the tissue up, but actually you've got a saggy capsule at the bottom. So the inferior capsule you actually haven't really recreated that anterior inferior glenohumeral ligament. And sometimes it's just inadequate. So this was never going to work. There was only 1 anchor, and I'm not sure it was even in the bone. So you've got to put enough anchors. Then on the bone side, so both if you're doing a bone block, particularly if you're just doing an eden-hybinette, you want to get that bone block right in the correct place. With a Latarjet, it's less important. It has to be super accurate because we're really relying quite a lot on the dynamic sling. But you can put your bone block too medially, you can put it too laterally, or you can actually put it too high. So this was an eden-hybinette that I saw, and someone had tried to do this eden-hybinette open, but they didn't go through subscapular. Somehow I think they tried to sort of go over the top and put it down. So actually the bone block was too high. So you can get your bone block in the wrong place. Then obviously, as I said, new traumatic episodes. So these guys want to go back to playing rugby. They want to go back to skiing, snowboarding and the such like. So that's just bad luck. So you can just have the same injury again. So when we see these patients, what do we want to do? So clinical evaluation. So the history, it's really important to go right back to the beginning. So you don't want to know just about this particular dislocation. You really want to know, you're doing a little bit of detective work. So you want to know about when they originally dislocated, how young were they, how many dislocations had they had prior to their initial stabilization. Then you want to know a little bit about their surgery. How well did they do? There are some patients that they'll speak to and they say, well, I never really actually felt it was that stable even at the time. And how well they recovered. Did they get to 100% or were they never quite sure? It's nice to get previous notes and imaging, but quite a lot of these patients are relatively young and they're transient. So sometimes it's very difficult to actually really get a history. So sometimes if you can get some, the notes or the imaging from before, that's really useful, but that's not always going to be the case. And you really want to know about the mechanism of the new injury. Was it a big traumatic event, or was it atraumatic? Sometimes you see these guys and 3 or 4 years down the line, suddenly their shoulder dislocates in their sleep. So a relatively atraumatic sort of event. So there's a red flag. This isn't a red flag to be worried about the patient, but pain is a red flag, because instability as a general is painless outside of when you dislocate it. So if a patient's coming to you predominantly with pain, then you've got to think they may have redislocated, but has something else gone on? Have they damaged their cuff, or have they got a neurological injury? So on the examination, obviously you want to do as thorough examination as possible. It really depends acute or chronic and how much pain they're in. Always look for a posterior component. Sometimes that's the thing that was missed out. And so if they've got pain, you're thinking about perhaps a cuff injury or a neurological injury. But always be mindful of a CRPS, and also some of these patients are looking for a secondary gain. So you just need to be a little bit careful. And the other thing just to think about is post-capsular arthritis. We've just heard about the reason we fix some of these patients up is obviously so they can get back to sport, but it's also so they don't get arthritis. Hannon spoke to us in his talk about that Havelius study where they followed the patients up for 25 years. Actually, that 25-year follow-up, they did a plain X-ray of all the patients, and actually 66% of them had grade 2 or above osteoarthritis on a plain X-ray. And an age-matched group only had 5%. And some of those patients that had got that arthritis has only had 1 dislocation. But when they looked at the patients that had got the arthritic change, the more dislocations you'd had prior to being fixed or afterwards. So actually, some of these people do get arthritis. And what you sometimes find is some of these patients come and they say they've had they've had some surgery. They say they've got a slipping feeling. They feel they're unstable. In fact, actually, they're osteoarthritic, and it's just the sort of the bone-on-bone slipping feeling. So some of these patients, it's actually they've got early arthritis, which is very unfortunate. Then obviously imaging, you really want to do as much imaging as you can. So sort of plain X-rays, MRI scans, CT arthrogram. Obviously, if they've got metal in between previously, that does make it a little bit difficult with MR. We've started to do zero echo MRI at our hospital, which is very nice. So it's an MRI scan, but actually you can get bone quality from that. So for patients that haven't got metalwork in, zero echo MRI is quite good because you can actually get CT quality look at the bone. So it's one investigation as opposed to 2. And when we're looking at imaging, we can sometimes get some clues. Did they have an inappropriate initial procedure? So we can see at that CT at the top, you can see that actually that anchor is in the bottom of a large glenoid defect. So probably that patient had pretty significant glenoid bone loss at the time of their first procedure. So probably they didn't actually get the right procedure. They've been better off with a bone block procedure, either an eden-hybinette or a Latarjet. Or particularly on MRI scan, if it's a recent injury, you can see a bone bruise. So that gives you a clue. So this is a new Hill-Sachs lesion because we can see there's a bone bruise there. Then it's really about decision-making, these recurrent dislocators. So if someone's has got frank instability and it's affecting their day-to-day life, then really some type of surgery is going to be required. A lot of these patients have only had 1 episode or intermittent instability. Actually, the vast majority of people are actually able to cope with that. They can modify their activities, and they're pretty keen not to have another operation. And if their dislocation only occurred on 1 event, it's worth perhaps seeing how they go. A lot of them do settle down, but obviously if they become a recurrent dislocator, then you're going to have to do something about it. But then you've got the great group of people that really want to be normal. They want to get back as they were before. They want to get back to playing rugby, to doing all of these contact sports. So that's a really difficult sort of situation. So really what you really want to do is you really want to try and minimize expectations. So really if you're doing revision surgery, you can't really give them the same guarantees that you could when you're doing it first time. So it's really difficult if a revision of a revision becomes quite sort of complicated. So you have to be pretty pessimistic. With regards to the surgery, unfortunately, there's no magic formula that's going to work for everybody. Even for a primary dislocation, sometimes we're not sure whether we're going to be able to get away with a soft tissue procedure or whether we're going to have to do a bony procedure. It's even harder when it comes to revision surgery. So there's no one procedure that's always going to work. And really, it's a bespoke procedure. So you have to take every patient on their merits with regards to their sort of bone loss, or soft tissue component, and all the various other things. So there's a pile of procedures that you can do, really from a revision soft tissue to a bone block procedure. You may have to even address the hill sacks either with a remplissage or an allograft or something else. So there's a whole pile of things to do. In truth, there's 3 basic procedures. So we've got the Bankart, the Latarjet, and the eden-hybinette. It's going to be somewhere in there that you're going to be doing your surgery. Obviously, there's a remplissage that you can throw into the mix if they've got a hill sacks, and if they've got a really big hill sacks, you're going to think about a human head allograft. So this is the sort of thing that you're going to be thinking about. And actually, sometimes the patients that have got really big issues with big bone loss, so they're definitely going to require a Latarjet, an eden-hybinette, or even an allograft, then there's no problem with those. You know that's what you've got to do. But there are these group of patients, there's an element of equivalence. You think, well, maybe I can get away with a soft tissue. Maybe I can, rather than doing a bone block procedure. And as a general rule, what we tend to do primary-wise, we tend to think, well, perhaps, as Len said, particularly if you're starting to do a coracoid transfer, there are risks and complications, much more so than if you do an arthroscopic procedure. So in the primary scenario, we tend to think about, let's try to do less. I think certainly when it comes to revision, they're not quite drinking in the last chance saloon, but you really want to make sure this is going to work. So I think if there's any doubt, you're better off doing a more thorough procedure than not. And this is just talking, I just mentioned earlier about sort of bone block procedure. So bone block procedure is really designed at extending the glenoid arc, so the bony part of that. So certainly eden-hybinette, what that does, it just extends the glenoid arc, and that's all that it does. So, but a coracoid transfer or a Latarjet procedure, it has a bit of a bone block, so it does extend the glenoid arc, but it has that extra component. It's that sort of soft tissue dynamic sling. And so Len alluded to this, these young contact sports guys, they've had a soft tissue procedure. Often they haven't got that much bone loss when they've redislocated, but I think they've got an element of soft tissue. They haven't got soft tissue loss, but soft tissue inadequacy. So for these guys, I'd be thinking about a coracoid transfer. I know people are getting quite excited about doing the arthro eden-hybinette, but I'm a little bit concerned that people are jumping in and doing those on younger people because they say it doesn't change the anatomy, but I'm not too sure how well they're going to do. The other thing to think about when you're doing revision surgery is a lot of the time it's not a clear pitch. Unfortunately, you're going to have issues with the glenoid, the anterior inferior glenoid, quite a small area, and we can have issues with retained metalwork. So certainly some of the failed Latarjets, eden-hybinette, I see sometimes the screw shafts have snapped off, so the screws left in the bone. Metal anchors can be there, and actually even suppose these absorbable anchors actually don't always absorb, and you can get quite a large sort of cyst. So there are some issues with the anterior inferior glenoid, so you have to think about how you're going to work around that. So are you going to try and extract the metalwork? It's pretty difficult. If you try to extract some retained screw shafts, the amount of bone you're going to lose, you're going to lose half the glenoid. Sometimes with the smaller anchors, hopefully you can bypass them, but sometimes if bypassing that, you're going to compromise the position, particularly if your bone block, then you're going to compromise your procedure. So something that we've just written about, we've just published a series of 10, is just using the suture buttons to fix the either the bone block, whether it's for a coracoid transfer or a Latarjet. Because it's got that guided system, you can actually pre-calculate where you're going to put your guide on the front, so you can actually work out a pathway that you can drill your hole, so it's going to bypass your metalwork. So you can normally find a safe zone, so you can actually work out the distance on the front of the glenoid where you need to put your guide, and then you can actually do that at the time of the procedure. And this is just a sort of a patient who had these snap screw shafts, and we worked out where we could actually put the sort of suture buttons. We measured down, and this is the post-op one. So that worked quite nicely. So in conclusion, failed instability, this is a really challenging problem. I think it's going to be increasing with instance because we are fixing up more people are living longer. I think people's expectations are a little bit higher, whereas previously someone would dislocate their shoulder at a younger age and they think, well, that's the end, I'm going to give up doing what I do. Actually, people want to live their lives, so people are now opting to get stabilized. So the more we do, the more problems we're going to have. So when you're looking at a patient or you're presented with a patient with failed instability, you really want to establish the reason for their failure. Was it an inappropriate procedure? Was there a technical error, or if they just had another accident? Choice of procedure, well, once again, I said that's multifactorial. So a lot of factors that you have to think about. So you want to look at the bone, the soft tissue, and pre-existing implants. In some ways, the good news, most patients are able to cope, and they perhaps aren't going to dislocate again. So the vast majority of people who've got failed instability surgery aren't going to necessarily want to jump in with surgery straight away, but there are always going to be those people who've got frank instability and the people that really won't get back to that. But the important thing is you really have to have a very frank discussion with these guys. You want to have really almost minimize expectations, so realistic expectations. You're not really going to be expected to really be 100% after you've had a revision stabilization procedure. One of the main reasons we're doing it is to try to prevent OA. And I think at the outset, we've been talking about trying to get people back to play. It's always a bit worrying if you're treating someone who's younger than you, they're going to outlive you. So they're going to dog you until the day you retire. So these guys are, in their 20s, and they're going to end up with arthritis in their 40s or 50s, the more times they dislocate. So part of it is actually getting people back to play. But I actually think really moving forward, we need to be stabilizing patients to actually protect their shoulders. And I suspect in 10 or 20 years' time, there's going to be a massive increase of people in their sort of late 30s, 40s or 50s requiring shoulder replacements because of instability episodes. Thanks very much.
Thanks, Graham. Another brilliant talk. Questions. So you've described the use of these suture buttons. So there are obvious advantages that you're not going to have. If it were to fail, you're not going to have any retained metal work that you're going to struggle to deal with. Do you believe? I mean, there is also the perception that if you're using screws, one of the complications of screws is non-union or even bone block resorption, and it's thought that perhaps this may be secondary to stress shielding from the screw. Do you think that the button might be protective?
I mean, I think the guys that are keen on the buttons have done sort of a lot of work, and obviously Pascal Below was pretty keen. He was just using a single button for his coracoid transfers. Now it's gone to double, and actually he seemed to get some really good sort of healing rates. And I think one of the reasons is that actually probably you get it really nicely lined up, so you really do get good bone on bone sort of apposition. Other guys are using allografts, and actually in Italy they're using horse allograft. And the problem with that, actually, it's the opposite. It doesn't resorb at all, and it's rock solid. It doesn't remodel at all. So they're having an issue that it's not resorbing at all. So I think with the screws sometimes, I think maybe we don't get them as straight as possible. I think we do sort of get the result. I think in truth, particularly for the Latarjet, the reason they came up with the Latarjet, initially they were just doing a coracoid tendon transfer, and then they thought they'd put a little bit of bone, so they had the Bristow, and then they've gone for the Latarjet. So I think that the screws and the buttons are interesting. I suspect that people are going to perhaps move more for the buttons for both a coracoid transfer and for an eden-hybinette. It does seem to work very nicely, and you don't have any metal work down the line. So even if you're thinking about doing a shoulder replacement, you don't have those issues. But I think certainly the button guys are really sort of pushing it. They're trying to claim they get less resorption, but I don't think there's enough evidence out there to really. I don't think that I'd advise someone, if they were worried that they were having lots of resorption from screws, that going to buttons is definitely going to get rid of it. It seems to be that it is beneficial, but I don't think there's any real evidence out there to really show that it's a difference. I don't know whether Len or Hannon have come across anything with regards to that.
I have no particular experience with the buttons so far. But on another topic, Graham, have you any experience with the bioabsorbable screws in Latarjet, either positive or negative? I think that they're less stiff, that you might get more bone.
I've steered away. I mean, like yourself, I've used screws pretty much all of my career. I've started to use some buttons, and one of the things actually sometimes, particularly with smaller people, their coracoids are actually tiny. And if you want to get sort of 2 decent screws in, you're a little bit sort of compromised. So sometimes you can only get 1 screw in, but the drill hole diameter for the buttons is only 2.7 millimeters. So I fixed up a gymnast. She was only 5 foot tall, and actually, you know, I got as big a coracoid as I could. I got the knee of it off, but the thing was only about 50 millimeters in length. But by using the buttons, I did an open latarjet. I could get 2 nice strong points of fixation. So I think they're advantageous there. So what I've started to do for patients who are smaller, I know their coracoid's going to be smaller, I'll measure that in advance. I'm thinking about maybe perhaps doing buttons for those, because I can confidently get 2 points of fixation. But I tend to use screws. I've never really toyed with any of the absorbable sort of stuff. I don't know, Len, whether you've tried that. I don't really have any issues with screws. I think, you know, you can take them out. It's not a big problem. I'm not sure that bioabsorbable is really going to help me.
Yeah, I think Gilles Volch published a series of, he used them for a period, but I think they had a fairly significant failure rate. But that was maybe 10 years ago. I'm not sure if the materials have advanced in more recent times. I know there's some of my colleagues have used magnesium screws. Or some composite of magnesium that seems to be
burst into flames.
Exactly.
Yeah.
It'll diathermy.
About the buttons, I don't think it's been described, but have you got any concerns? Because your guide, you know, pushing your posts out the back to bring your sutures out and then slide the buttons in, you're not a zillion miles away from the suprascapular nerve.
Yeah, so you've got those so the 2 sort of branches that go right down the bottom. So no one's really sort of looked at that. I think, well, they've looked at it for screws, and they basically, there's just an omega angle. So as long as you're relatively parallel to the glenoid, you're going to miss it. It's about, if you're sort of 10 millimeters medial to that. So I think on the what they say on the buttons is, because it's only got a 5 millimeter offset, as long as you've got your guide flat onto the glenoid, then actually the drills at the back should miss that. But I don't know. Len, have you used the buttons at all for Latarjets?
Only on a cadaver.
Oh, yeah.
Yeah. I mean, that's the reason why I asked, is because I did a sort of, last time I was in a lab on a cadaver, and then I was interested, and I, on a couple of specimens, cut down posteriorly, and it's, you know, you're pretty close.
Yeah. Yeah, I think people, I don't know whether Hannon or Len, you've ever really had any issues with damage to the suprascapular nerve from, obviously when you drill your screws through and you screw those through, people talk about that a lot. I mean, I must admit, I haven't specifically looked for that as an issue, but to my knowledge, I haven't really come across any patients. I've done a fair number where that's been a problem. I don't know whether either of you two have actually ever had that problem or seen it. Have you seen it then?
Yeah,
Unfortunately, yes.
Yeah, I had one patient, and he, I mean, the screws looked good on X-ray. He came back. The physio picked up that he'd some wasting, and he had some weakness of the infra, and the X-rays looked the X-rays showed the screws looked good, and they were, you know, maybe a millimeter or 2 proud on the CT. But I mean, you'd certainly see X-rays, like standard X-rays in the French textbooks of like that would be 3 or 4 mils longer than that.
Yeah.
We got EMGs, which was a little bit inconclusive. So I took the screws out because it had healed, and over about 6 months he recovered. So it seemed to have been causing some irritation or some. That was the only patient that comes to mind.
Len, you've seen that as well, have you?
Yeah. So I mean, it's really important for the guys to realize technically. I agree 100% with Livio. You've got to be very careful. You know, make sure your graft is on the lower half of the glenoid, and your direction of drilling it does not aim superiorly. If anything, aim slightly inferiorly if you're doing it open. And if you're doing it arthroscopically, make sure that you're trying to be parallel with the glenoid and not venturing medially.
Yeah, I think the more parallel you are,
really
the more
important.
inferior, the less chance is to. But I think it's quite difficult to truly mitigate against it, because there'll obviously be aberrant sort of things. But I think, as Hannon said, being aware of it, and I imagine it's something that, and it's right. Not that there's any consolation, but it's actually the little branches. It's quite far down, so it's not the whole of the suprascapula.
Yeah.
If you're not comfortable or trained in doing Latarjets, you're better off doing a stabilization, and then if they fail, send them to somebody who is experienced in doing Latarjets, or train and do them, whether you do them open or arthroscopic. And I think that's very much reflected by the Americans' complication results in the study by Geisler, which is a reflection of the American experience of taking on Latarjets.
Yeah, it's definitely a very powerful procedure, but it can also open a massive can of worms.
Just ask Graham, in the revision setting, how do you manage the very large Hill-Sachs lesion? Are you a remplissager, or do you use a bone graft, or what's your take on that?
Yeah, so it really depends on the size. So I'll do a bone. Actually, one of the indications to do sort of one of my few indications left doing arthro Latarjet is if I want to do a remplissage at the same time, because I can do them both arthroscopically, and so really, so that remplissage is my go-to. But some of particularly the epileptics who've got those massive sort of Hill-Sachs lesions, so there are 4 or 5 guys where I've chosen to do an osteochondral allograft. So I've cut out a chunk and matched it and put it in. But I know that some people have used a sort of the sort of hemicap to fill that in. But they've been the ones where it's almost looked like it's nearly 50% of the heads that's missing. So if it's pretty large, I'd perhaps be thinking about doing an arthro Latarjet and trying to do a remplissage at the same time. I don't know if are you able to do an open Latarjet and a remplissage open? Can you do?
I've done a couple where I've done a open Latarjet combined with an arthroscopic remplissage.
So you've done
in the epileptic.
Yeah.
I've done a couple where we've done a pretty big exposure, and I'm doing either a eden-hybinette or a Latarjet, and I've opened up the interval and rotated the externally rotated and put a Homan over the top, and have done an open, used these sixters to pass the sutures through the posterior cuff. So I've done an open remplissage with some bony procedure at the front.
Yeah, I mean these guys are really difficult. I mean these are the ones at the top of that thing. They've got frank instability, and really, I mean, sometimes I've never done it, but I know that sometimes it's so big people will consider doing a sort of resurfacing because there's so much bone, and I suppose that is an option if it gets that big.
Yeah, because one of the hospitals I work in is a national neurosurgical center. So we see people who unfortunately come in with the seizure, present with a seizure, and then it turns out they have a brain tumor. And so some of those, I've had small series of those where the prognosis is poor, and I've just jumped in with done a resurfacing, and they just keep them in a sling for a couple of weeks, and at least they can go and organize their affairs.
Yeah.
Cool. Well done, guys. So to sort of wrap it up, I think now what we will, I'm gonna share screen. So we've got a summary slide for each of the talks we've had. So this is Hanan. Basically, he talked to us about the unacceptable high risk of recurrence in, the young, fit, active individual, the athlete. And we do know that surgical intervention can reduce the recurrence rate of their instability. Definitely, there's no argument that it doesn't improve quality of life. It absolutely does. Recurrent instability, we do know, this is proven, that you get progressive soft tissue problems and bone damage, cartilage defects with time. And there's and he's demonstrated there's better chance of return to play versus recurrent instability surgery. So if you repair soft tissue lesions early, then you get back to your sport quicker. But this is a recurrent theme throughout all the talks, and you will know in your own practice that it's a shared decision-making process with the patient to meet their needs and their expectations. And I guess when they're an elite athlete, that shared decision-making process is with them and the other sort of the people that are helping them achieve, which is their therapists and the team management. Len spoke to us about anterior instability in the athlete, higher occurrence rates of bony Bankart injuries, and this is probably due to the fact that the multiple glenoid growth plates fuse rather late, and the anterior inferior one doesn't fuse until your mid-20s. Low recurrence rates with Latarjet procedure, but as we've heard in Graham's last talk, there's higher complication rates compared with direct repairs, and therefore in younger individuals, you may consider doing a soft tissue reconstruction after discussion with the patient. In season traumatic instability, you can complete the season with non-operative management, but you'll need to base that on a clinical assessment and the presence of either minor or major bony or soft tissue lesions in their shoulder. And then you need to consider patient pressures and factors as well as their pathology. And lastly, Graham, who is our chap who's been in the army, and he's keen with his weapons, and he does look reasonably similar to this gentleman. He's the shoulder mechanic, and he told us that early failure is present in about 10% of individuals, possibly late, which is described 3 to 5 years at 20%. But often these failures, you've got to think, why have they failed? Is it you've chosen the wrong patient, the wrong operation for them, you've done something wrong technically, or have you just been unlucky and they've had a secondary traumatic event? So history is important. He pointed out the red flag of pain. Instability doesn't necessarily cause pain, and there may be something else going on that you need to evaluate. You need to assess them appropriately with x-rays and three-dimensional imaging. And then if they're frankly unstable, well, obviously they need surgery, but there are a whole bunch of copers out there, so you need to assess what their aspirations are in the future. Very wisely, you need to minimize expectations. I remember working for somebody early on in my career, just said, always tell them it's terrible, terrible, terrible. So whenever you get a good result, they think you're a hero. So there's no one formula that works for everybody. Graham sort of suggested that, go small, particularly if they're young, but perhaps the slightly bigger operation may be the one that you want to do for them or need to do for them to prevent there being the need for a revision. And as we discussed, there are problems with retained metal work and perhaps buttons or other things that are being developed might be helpful in the future. So thank you very much. I think we've gone roughly to time. I would like to extend my thanks to Len Funk, Helen Mullett and Graham Tytherleigh-Strong, a really superb faculty for this OrthoHub XYZ webinar this evening. So thanks for your engagement, everybody, and have a fantastic evening. Cheers, everybody.
Thanks, Livio.
Thanks very much.
Take
Well
care.
done, Livio.
you.
Thank you.
Good night.